topic that it's much more related to the general practitioner as their daily basis, but I didn't want it to be more in details or more in theory. Okay, it's more about photos and some of the cases and what's the guidelines. It's like if you have a case that you want to see, what's the track that you want to go and to find a way how to finish it. So mostly the retreatment, okay, it's just like if you have a failed, which is a conventional root canal treatment, for many reasons, okay? Maybe it's like a failed anatomical, you couldn't find the canal, or maybe an obstruction of any type, or a failed coronal part, okay? And that type, okay, then we need to go for non-surgical retreatment, which is the retreatment in another way. If the non-surgical retreatment failed, okay, we cannot immediately go for extraction. We still have an option, which is the endodontic surgery. Okay, now endodontic surgery is part of the endo treatment, and it has also a good prognosis. Part of the surgical endodontics, okay, is the intentional presentation. Yes, it's less in the way and the criteria for the choices for the treatment because it needs a specific teeth, criteria for the teeth, okay? And if these all didn't work, then we go for the extraction, implant, whatever the choices. So the scope of this lecture, okay, it will be going from the coronal part, which is the criteria of the restoration, either to remove it or to keep it, okay? The second part will be about the canal obstructions, the post-in core, and about the calcification, ledges, instruments, okay, separation, and perforation repair. The last part, okay, was about the removal of the root canal filling, and this is about removal of the Gutta-Percha or the carrier base Gutta-Percha, and we have the silver cones, or it's like hard paste, whatever, there is some type of obturation in these canals. After all of this, we'll talk about the healing process and the timing, okay, and what we expect. So we will start with a simple thing. What's the criteria that we can choose from it, okay, to keep or to remove, okay, the coronal filling before we go for the retreatment? First of all, let's see what we have, okay? If we talk about restorations, we have amalgam and we have composite. Now, if we'll talk about which is better, okay, in the way if you want to keep, okay, for sure, okay, the bonded restoration because it's bonded, okay? But if you think there is an undermined decay or any reason, you have to remove it. The amalgam in all of the way, okay, you have to be removed. The way because it's mechanically retented and because of the shredded amalgam pieces during the axis to do the retreatment, it might fall inside, okay, the canal. Also for the reading, okay, of the apex locator, it will give you a wrong, okay, reading because of the metal at the top. Now for the crown, we might have a metal, we have a porcelain, or we might have a bridge. All of this one will affect our way or chooses or the way how we choose the way how we remove it or go through the crown. Let's go with some of the cases. A case like that came to your clinic, it has a lesion, and it has a silver point. If you say to me, okay, that you want to go through the crown to do the retreatment, before all of this, okay, we need to know the reason of the failure. If this is a case for 5 years, if you told me, okay, the reason of the failure is because it's the silver point, I will say to you, no. Silver point per se itself, it's not a reason for a failure, okay? There's many cases, which is success. Maybe the corrosion, okay, that happened to the silver point, but how this corrosion happened? Because of the leakage. If you can see this crown, okay, there is a leakage. And if you focus more, okay, which is also straightforward, okay, x-ray, there is a canal on the distal side, okay? You can see it still is not filled or any way had been touched. And you can see also the leakage on this side. So this is a choice that you have to remove the crown and you have to assess the case and you have to know if it's restorable or no, also by taking bite wing. And also if you have like a specialty of prosthodontist, if you're not the one who's doing it, preferably before you start this case, he's the one who will go and check this case. A case like this with a large amalgam. If you say to me, okay, I will go through the amalgam and I will just only keep this part. Now, if you keep this part, okay, it's not retentive. In a way, okay, it might fall down, okay, and it might also, the amalgam itself, it might go through the canal and also give you a false reading when you do the treatment. So in a case like that, you have to remove the whole amalgam, and you might use like a bonded restoration or a GIC, or you might use an ortho band, okay, to hold the tooth before you go and do the retreatment. A case like that will come to my clinic, and you can see there is an ortho band. It has an ortho treatment. Now the orthodontist say to me, okay, the patient's complaining of pain. This endo treatment has been done 4 years ago. And I was wondering, okay, if there is any forces or anything that happen inside this area. But you can see it's a well-fit crown. But don't be like masked by this one. You need to take a bite wing. You'll be surprised to know if you take a bite wing, look the way how it's sealed, okay? This is not only a way of composite, okay? There is a leakage happening on this one. Actually, the crown is moving, okay, from the side, okay, during the ortho treatment. So before you go and decide and go through that crown, okay, you need to remove this crown. What evidence base do we have that support the way that we remove the crown or remove the filling? This is a good study by Dr. Abbott from Australia, which he has about more than 200 cases. And he was checking the patient before he go and remove the filling or remove the crown for these three things: for the decay, for the cracks, or for there is any marginal breakdown. So for the decay, before he remove the filling or the crown, he found almost about 19% of the cases has a decay. When he removed the crown or the filling, he found almost 86%. So this is a big change in the way how you look to your practice. If you say to me, okay, your friend is a good prosthodontist, okay, he did it like 2 weeks back, and the tooth was vital, but because of the preparation, it becomes a pulpitis, okay, you might go through it, okay, if it's a good well bonded, okay, and it's sealed, okay, crown. But also take a bite wing, okay? You will not expect, or you might be surprised to find many things, okay? That's the only option. But if you say to me, okay, a case that had been 2 years and you don't know who did it, okay, just remove the crown, okay? Send it to the prosthodontist for evaluation for many things, okay? You don't know what's underneath it. A decay, okay, of 86% of the cases in this study, okay, cracks or marginal breakdown, it could be the reason of the same operator or the one who removed it. It might crack it and it might cause it. So, but decay, it cannot be duplicated, okay, before and after. It's a decay. So it's a micro leakage and it's a bacteria that happened underneath that filling or the crown. So this is for the coronal part. So the tip from this, all of this, try to remove the filling and the crown, and this is the best way, okay, to go and find what else inside, okay, the tooth. Now, when we have a canal obstruction, we're talking about post and core, and we have calcification, we have ledges, we have instrument fragments, and we have perforations. We'll talk about each of these in a brief way with some tips. A case like that, you will be surprised to see many crazy things, okay, that can come to your clinic. At the beginning, when I was seeing the pictures and in the Twitter and the Instagram, I would say it's a Facebook, okay, or just like a Photoshop of things. But when you see it, your personal, okay, in your practice, you're surprised, okay, the previous dentist, okay, he couldn't remove the previous post, so he just kept it and he put another post, okay. So in a case like that, if you want to go through the crown, no way, okay, you need to remove the crown, okay, but even before you start, that's a big deal between you and the patient. You will not touch that tooth till you tell the patient, I might not fix that tooth after I remove the crown. You might have non-restorable tooth, okay, after I remove it, because when I look to it, okay, the amount of the root and amount of the crown root ratio, okay, you have to give all and to measure the risk and benefits. In a way to remove this one, it's much more easier, okay, to remove the crown. You can remove the other piece by the ultrasonics. And I will show you some of the tips how to take it out. A case like that, we need to know the failure of a case. If you say to me, okay, the prognosis of this case, you need to remove the post and you can see the canal is not clean and shape. I will say to you, this is a good prognosis after I finish the case, because I know the reason before the start, it was not clean and shape. In the opposite side, a case like this, which you have a short post, maybe an overextended filling, but it's not a case of failure. In a case of this, you need to measure all the way how it looks like. You might check also the neighboring teeth. Is it vital or no? You might go and retreat many cases and still the same reason. If there is a sinus tract, you need to trace that tract. Always trace it. Even if you look to it, you might be surprised it be traced to another tooth. So you need to make a balance between each case from another case. I prefer a case before I start, I know what's the reason for the failure. And if I know the reason of the failure, I can see how much success it is. When I have a good case and a good treatment, and still there is a lesion, that case is much worrying me than the regular case with the weak root canal treatment, because I'm looking for the unexpected things. A case like this, the reason was not the premolar. The reason was this tooth was a vertical root fracture. It was a single isolated, pocket, and it was one for extraction. So even if I remove the post, I remove the filling, still there is a fracture. Now, one of the tips, of the vertical root fracture, it's a single point drop of the pocketing. And what we have something called a J-shaped lesion, or what you call a hollow space, And this is what we have here. It's like a shape of a J all the way here. You might have an isolated, area. If this is a straight canal and I have a way of a lateral canal here, yes, you might have a way and go on retreatment. But this was a clear, case after we removed it. It was a vertical root fracture. So it's not all of the cases. You have to check very carefully. Don't give guarantees for the patient unless if you know what you're dealing with. This is the most important tools in an endo specialist clinic. Ultrasonic tips, it's not like a scalar tips. No, this is a diamond coated. You might have a round tip, a straight or fissure tips, and we have the smooth one. These are very important. Even if I have the best chair, the best microscope, without these, I cannot do anything. This is really one of the big secrets of the endodontist practice, You can go and remove the calcification. You might find the mesobuccal canals. You might go and also drill around the post, to make it looser, Also for separated file and instruments, many things can be used with the ultrasonic steps. When you have like a post, especially when you talk about a screw post, mostly, if you can keep, when you drill, the top part, which can be unlocked by the unscrew of the same screw, and you can unscrew the post. This is one thing. If you cannot do it and the head of the screw is already cut, you might go around the post, with the diamond, ultrasonics, and you make it in an anti-clockwise. It's like you are unscrewing the post, and easily it will be going out with you, and then you can continue with the retreatment from this point. Now, the casted post is one of the difficult parts. We might have in a direct way or indirect way, which is posted or like poured in the lab, But both of them, it depends on about the sealability of the crown. If you have a good sealed crown, if you have a well-fitted, post, and you see there is a weak root canal. In cases like that, I want to just go and remove all of these, and then after that, just to go for the last 3-4 millimeter from the apex and clean it. I will just go directly to the surgical part and just cut the root area of 3 millimeter and clean it from the apical part. If the crown is not fitting well and the post there is a space, then that's the point. You might use ultrasonics and vibrate the first part, and after that it can be taken as a one piece. Now the difficult part is this type of the casted post. This type, usually when they use it with the molars, it consisted of two pieces. One piece is the core with the anti-rotation post part. And the longer one, they made a hole at the part. So it comes separate. So you just insert the cast post. Then after that, you go through the opening from the core and cement it inside the large canal, which is already prepared for that purpose, either palatal or the distal. Now, the only way to remove this one is just you need to section it. You section it from the mesodistal, and the way how the anti-rotation is posted. And then you can take it as two pieces. Fiber post, okay? Now this is really a difficult post, okay, to remove. Now the diameter and everything, it depends on the way how it's drilled. You might use the same drill, okay, that created the post, if you know that drill, or you might go with the ultrasonics, or you might use something called a gyro tip. A gyro tip, this is a special tip drill, okay, for the fiber post. The end of it, okay, it can create a heat when it's drilled through the post, and it can melt the middle part till you go all the way and remove the post. Now, if you talk about this case, for example, this case, okay, it has a lesion. This is what's really a nightmare case, because when you look to the post, it's well fit. You can look to the crown, it's fit well, and you can see the root canal, it looks nice. So always I will think of another, okay, lateral canal. For any reason it was not clean in shape, or I might think of fracture. That's the only way of I think of it. But if you think to me, okay, go and remove the crown and remove the post, I'm destroying the tooth. In a case like this, I will go surgical. And when I do the surgery, then I can explore the area. I can see if there is any crack or fracture or any area in that when I do the surgery. You might find in the market many of the tools and the kits. This is like from a company, this is from also from Rodel, okay, and these are okay for post or whatever drills to be removed, but this is really extra money that you will not use, okay? If you want to buy something very nice, okay, I can help you. It's called the micro forceps. Micro forceps can be 45 angle or a 90 angle, okay? Small forceps that can go and rip things, okay, from the coronal part and can help you, okay, in a way that you're holding with your tweezers. Sometimes it's very thicker, okay, to go through the opening of the axis. You might try to go to widen it. This is a nice piece, okay, to go and to remove the small fragment or instruments from inside the coronal part. This is a video, okay, how to remove a cemented post. Now, the difficult about the cemented post, okay, it's more remaining about the cement. So we are going with the ultrasonics, okay. It creates a heat, okay, and that's why you need a coolant, water. And we want to break down the cement around the post. And by the way, we can see the motion. We are not going like the otherwise, okay, or unscrewing it because it's cemented. It's not grabbing in the dentin. It's more holding about the cement. You don't want also to go with your drill, okay, all the way to the canal, okay, and try and drill inside. You might create perforation or weaken the root. So you only go with the ultrasonics. It's very safe. You might use the ultrasonics with the diamond coated, or you might go with the passive one when you are closer to the apical area. And then you can go and continue your retreatment with the Gutta-Percha and how to remove it. This is one of the difficult part, okay, is the calcification. When you say about calcification, a case like this, they tried, okay, to go and to find the canal. There is a lesion. So there is a lesion, that means there is a canal inside. Either maybe it's a 2 millimeter, 3 millimeter, or 1 millimeter, okay? There is somewhere here, okay, a bacteria is growing. Some will say that maybe there is a fracture or crack. That's true. But, okay, just to go and continue and drilling all of this way, okay, it's a crazy part, okay, unless if you have something and we are using it, okay, and this is the time you want to go use it. It's the CBCT, okay, a 3D. You want to see, okay, if there is a canal, okay, and you want to go, okay, then you can drill. If you say to me 2-3 millimeter, okay, and I will catch the canal at that point. Good, okay. I might use the ultrasonics. I might use the C files. This is K files, okay, but it's stiffer files, okay. It comes from 6 to size 15, okay, and these are stiffer files, okay. The taper at the last 4 meter, it's larger than the K file, and that's why it's a stiffer file. It's not easily that bend like the size 6 and 18, so it's much more stronger. You need editor, okay. This is will also to dilute, okay, the calcification. One tip also, it's what we call the Muntz burrs. Muntz burrs, okay, it's a long burrs, okay, it has different sizes, and this one had to be used carefully because you need a guide. So every time you go drill through it, so you need to see it through the way and to drill all the way at the end. Now, if the CBCT, okay, didn't show me any canal at the beginning, okay, of the treatment, it may be at the end of the last 3 or 4 millimeter. I'm not going to drill or use all of these. I'm going surgical, okay, and I'm cutting all the way 3 to 4 millimeter and just do the retrograde filling, and that's it, okay? You not just go and continue the danger, okay, because we're already now in the danger zone of this place, and you might strip, perforate in the tooth, and we went from somewhere failed prognosis to hopeless tooth. So CBCT is really a very excellent tool, especially when we have a limited zone that you might go, or a limited field that you can go and see what's going on these cases. Now, ledges, okay, it can happen, but most of the time when we go with the dry canal or use stiffer files, okay, hand files, and then we suddenly stop with something hard. The easiest way, okay, you need to go back to your track. So just only take a size 10, use the solution in the canal, pre-curve it, okay, and try to bypass that ledge. When you bypass that ledge, okay, stay there, okay, and just go up and down for 1 millimeter till you smooth that area. Then after that, you go with a size 15, size 20. After that, you can use your rotary file. You will not use a rotary file to bypass ledge or just try to continue, because you might use it to go for a transportation, or you might go for a perforation. But otherwise, okay, still, okay, a ledge is much more easier. One of the mishaps that might happen, okay, and especially, okay, when you have mesial root, okay, or mesobuccal root, okay, the axis, okay, but sometimes it can cause a gouging or somewhere, okay, a way that it can be like a ledge. So to go back to axis it, then you need to straighten your axis. The instrument fragments, which is like most of the nightmares, okay, people think that we can always remove the separated file. No, okay. Some of people will show their cases how to, and they are removed, okay. But all of these cases had been removed. We keep some, we can't find some. It depends on many factors, okay. If the separation happened at the last finishing burr file, okay. If it's at the first file, okay, or any reason, okay, that might happen. So for a case like that, okay, we need many instruments. First of all, okay, you can use the Munspurs, you might go to the case to them, you might use the C-files, and you need ultrasonics. But before of all of this, you need a magnification. If you don't have a microscope, okay, if you cannot see the separated piece, you cannot do anything. You might damage the area and you cannot go and do it, okay? Now, what's the things that can control me from, okay, going, okay, and removing that piece, or just to keep it? If that piece, okay, was like the last file from the shaping files, okay, or finishing files, whatever, but it's like a larger file, like 30. And I'm sure that I clean and shape that file, that canal. Okay, I might keep it at that point. If this filled tooth, okay, is a vital or it's a necrotic tooth. If it has a lesion, okay, it doesn't have a lesion. So anything of these, okay, that the amount of bacteria is more than the amount of the waiting, okay, and watching this case is more when we have it. When you have a vital tooth, that means we have an immune system. When you have immune system, that means we have white blood cells. So the bacterial count is less. When we have a necrotic tooth, okay, or a lesion, a tooth with a lesion, okay, that means there is a lot of bacteria there. So I need to clean and shape more. I need the sodium hypochlorite to go to that area where we have the bacteria. So when we have this fragment as a smaller, okay, sizes at the beginning of the treatment, that means the prognosis is poor, especially when you go down all the way to the case with the lesion. Now, is there any way other than these things? Okay, yes, there is many ways, okay, but we can go first of all in a tips way, okay, with the gaze glidden, okay, and we just try to open the axis, find the separated piece. Then we use the ultrasonics, but this is another way or tip. We don't go with the ultrasonics and use the area where there is the stress on the separated file. And you can see from the images, okay, that it's not this area that we're looking for when we do the ultrasonics, okay, vibration. We go with the area where we have the more stress on the angle, which is this part. And you can see there is a small bending on the ultrasonics, okay, and this is where area that can easily, I can remove it, and it has a list file. You need editor, okay, and you need to vibrate more. Now, when it starts to vibrate, okay, it can easily come out. There is something we call the loop, okay? It's like a hook. It's like a fishing hook, okay? Which is like, can be hold and take it out. But you cannot take it out unless it becomes loose. So you need to do the steps, okay, to loosen the separated part, and then you can take it out. This is a video, okay, of how we made the access. We expose the separated file, and then we go with a diamond, okay, ultrasonics, okay, and we just go. If you can see the motion, okay, it's anti-clockwise. It's against it's the opposite direction of how the file is motion, because we want to loosen it. So when it starts to become loosened, okay, then we go for a smoother, okay, ultrasonics. We fill it, okay, also with the editor. And then after that, okay, we can go and take that piece, either with the loop, or you can go with the smoother, okay, ultrasonics, and that we can take it out. Now, in a difficult point, okay, this is a thick root. If you have a very thin root or a very curved root, you might expect that the risk is high. You might have a perforation, you might have a stripping perforation, you might have transportation, many things. So all of these, you have to discuss it with the patient before and you start any treatment. Do we have kits? This is one of the kits. It's called IRS. It's the instrument removal system. The way how it looks like or how it removes, okay, it depends on where is the part had been separated. If you go to the apical part or the middle part, then the sizes, okay, of the hand, which is like a small drill, okay, it can be used. Okay, the size will go all the way, drill around the separated file. And then the same corresponding size of the same driller, okay, can go and you just untighten it and it has a piece that can still grab and you can take it out. This is one system. Another system which is very famous is the Terucci kit, okay? This one has a loop and has ultrasonics and have so many things. But all of them is the same concept. You need to clear the path and clear the area, and you can see the separated file. If you cannot see it, you cannot remove it. One of the interesting systems is also by Zumax, okay? It has a trephination burr, okay, of different sizes, and the same size of the trephination burr, okay, it can be the same correspondent. It's a larger or thicker, the same way how it was with the iris. So I can show you a video of this one from the Zumax, okay? This is a block which they have a separated file. We can go with the GG, which is the gate skeleton, size 1, all the way to the separated file, all the way to the separated file till we touch it. Now this is size 3. Size 3, okay, has a trick. Now we will modify size 3 to cut half of the drill. You can see it's flat now, okay? And this can flat your area till you look to it as the previous videos, how we can make this way and can become straight. Now, okay, you can see from inside how's the file and the preparation, how it look like. I go now with the trephination burr, which is the smallest one, because we are almost near to the apex, which is the root is very narrow. This trephination burr will go around the separated file, and you can see now it's become looser, okay? And then again, okay, you go and just to make enough space for the microforceps, the same corresponding file, and then you can go and grab it and take it out. Now, this is easy as a demo, but it's a real patient, okay? Many factors can happen. The angulation, the tooth position, the patient position, the timing. So it's not really an easy as it is look like, but you know the concepts and how things are done with these cases. Now you can see how much damage we have. This is not a thick root, okay, a very thin root. You can see the way how it looks like. It's easy for this one can be cracked in the future, okay, or creating, okay, a fracture. So all of this one have to be in the mind of you and the patient and to look for the risk and benefit if you want to go and remove these instruments. Perforation repair, okay, many things, okay, can happen from the perforation or how perforation can happen. Pulp capping, okay, as a direct pulp capping, We might have a pulpotomy or pulpectomy, okay? We might have a furcation perforation. We have a lateral perforation, episectomy, okay? All of this one can be used, many of the material. We have the MTA, which is the most common use. We have the biodentin, very few people, but it has a really a good future. Bioceramics now, which is the competitive of the MTA. Now, when we talk about the perforation repair, three things that you should be in mind that can increase the prognosis of the perforation. The time of the perforation, if it's happened today, it's not like after a year. The longer the perforation, the poorer the prognosis. The size of the perforation, the smaller, okay, the good prognosis. The location of the perforation, the more apical, okay, it's the higher prognosis. So this is a case, okay, a video case where a retreatment was started, but for a reason, okay, there was a perforation in the buccal wall, okay, and you can see from the bleeding and you can see the x-ray, it's lingual to the buccal canal. In a way, how to handle this case, you need, first of all, okay, to stop the bleeding, okay? You might go with adrenaline or you might go with a hemostatic agent in a way to control the bleeding. Drying the area, okay? And then after that, okay, you might use whatever the material choice you have, a biodentin, or you go with the MTA, or you go with the bioceram. Now, if you go with the MTA, okay, nowadays we have the fast-setting MTA, which is like the Angelicus, okay, brand or micro mega brand. It's most like 15 to 30 minutes. You can have a full set MTA, not like the previous one that you will wait for 24 hours. So when you apply the MTA, like what you are now having with the plugger, okay, very gently to the area where we have the perforation. Be careful not to cover the buccal side or the Gutta-Percha because it will be a headache for you in the next time to go and to retreat. You might try it and pack it more, okay? Now, if there is an excess of the MTA outside of the tooth, okay, it's not a problem, okay? It's very biocompatible, even the bioceram, even the biodentin. All of them are biocompatible materials, and it has a high good prognosis and doesn't cause any foreign body reaction. And you can see the x-ray. We try to save the tooth, okay, it might look poor prognosis, but it's better than extraction and going for implant. Many of the things can be controlled. Now the root canal, okay, we finished now from the obstructions. Okay, now we go for the regular root canal, okay, and the type of the filling that you might have inside the root canal. We have the Gutta-Percha, which is the regular one, and we have the carrier base, okay, Gutta-Percha, either a plastic or just a main core Gutta-Percha. We have the silver cones or silver points, and we have soft and hard paste. Now these are some of the old, some of still the use, especially North European, okay, they use it as sealer, okay, or something that can cement inside the canal. Now, when we go for removing the Gutta-Percha, now when you have three parts, A, B, and C. A, which is the coronal to the middle, B is the middle to the apical, C, which is in between, if there is any fences or anything between the canals. Now, A, you can go easily with the gate skeleton, okay, and B, okay, if you can avoid using the solvent, it's much better because it can stick to the walls or might push it to the apical area, okay, but gates, okay, as a choice. H-files, okay, it's one of the best choice, especially when you have an overextended, okay, Gutta-Percha. You might go and just overextend your H-file beyond the apex, and you might go and take all the whole piece with you. Also, there is a risk that you might cut it and you push it. So it depends, and you have to look to the X-ray, how diameter is that Gutta-Percha. If you go bigger than the diameter of that Gutta-Percha, definitely you will cut it. So you need to be less in the size so you can pass and you can touch it and then you can grab it with you as a one piece. Solvent is a choice, okay, but it's really, if it's something that is sticky at the apical part and you cannot remove it, then you might go and use the solvent with the H-file and to remove. There's many rotary files for retreatment, but I'm looking for a consumable way, okay, that you can have many things in your clinic and you can just go and remove the Gutta-Percha, and you don't have to have the fancy drills just only for retreatment. You can use your own rotary file to remove the Gutta-Percha. Now, the carrier-based Gutta-Percha, which will have a plastic carrier, okay? And this is a bad one, and I really hate this product because it doesn't show in the X-ray, okay? And it's really filled with the plastic, and it might push so much of the sealer outside. Now, the other thing, if you want to do a retreatment for this one, you cannot go and just, because most of the time, you want to do the retreatment and you don't know that there is a carrier base inside. You just open and you just surprised that you see the grayish color of the plastic carrier inside. Now you're in trouble, okay? So the only way that if you want to go on through it is to use a solvent. This solvent will solve the Gutta-Percha around the plastic, and after that you can loosen the plastic. If you want to go through the plastic, it will be a hell of a time because you will melt it and you will destroy things. So try to loosen the Gutta-Percha around it, and then after that you can take the plastic carrier. Now, if you like this type of Gutta-Percha, okay, you can go with the Gutta-Core, okay? That's also a good product from the same company, Dentsply. That Gutta-Core is the main bulk from inside. It's a Gutta-Percha. So this is like a normal Gutta-Percha, and you can go and just remove it in a regular way with the case skeleton, H-files, and whatever, if you want to use the solvent. But I don't prefer it in all cases, but in really the sticky part or the last 2 millimeters that cannot be taken out, you might use the solvent. Now the silver cones or the silver points. This is the previous case. You can remove these pieces, okay, but the bigger tip that you have is just try always to keep that coronal piece. Don't ever try to cut that piece, because if you could keep these 3-5 millimeter, okay, intact, it will make your life easier just to take it out. So in this case, okay, you'll remove the whole crown. You might go and use H-files, okay, or use like 2-3 files and then twist it and you might take it. Another way is after that is use what you call Stiglitz forceps that easily can break the silver point seal, but you have to be aware, okay, it could be rusted, so you have to be careful, okay. You might use a file just to vibrate, use some solvent around. Ultrasonics, okay, it's a good choice, but when you want to ultrasonic, you will not use the ultrasonic directly to touch the silver cones because it could shred the silver and it might cut it. So you might hold a tweezer and you might touch the ultrasonic on the tweezer. So it's indirect way can vibrate the silver cones, and after that you can take it one by one. Now, this is the difficult part. This is like some treatment that's used in North European, like they call it the resin red, okay, it's a mix of resins, and they might fill the canal with the resin, okay, and these cases are too tough, okay, to be removed because you cannot even locate the canal, you cannot go through it, you might use H-files, solvent, editor, ultrasonics at the end, okay, you might go and just go surgically and do the epico instead of going and retreating these cases, especially when you have a long span bridge. If it's safe for the tooth, you need a CVCT for these cases. Luckily, it's not so much, okay? I haven't seen only 1 or 2 cases, but back in the US, there was many of these cases. So it was a difficult cases. We don't have choices. We just reach the point that we cannot go through more, and we just follow up, and we might go for a surgical or extraction. So you just want to make it in your mind, you might have some of this type of obturation. This is the whole thing about the coronal and the removal of the obturation and the obstacle inside. Healing, okay, of a lesion. This is one thing which is I'm interested just to deliver it, because some people, okay, when you have a lesion, okay, you want to wait for the lesion to get healed before you go to do the final restoration or do the final crown. It doesn't work like this way. As a literature, okay, that the complete resolution of the healing, okay, it might take 2 years. So 6 months, it will start to resolve. 1 year, almost 60 to 70% of the lesion. It depends on the size, okay? 2 years is the complete resolution. It might take longer, it depends on the case, it depends on many factors, but all of this one is evidence-based. When I say evidence-based, this is the Okay, the evidence level, systematic review, randomized controlled trial. But when I give you the evidence, I'm going from the systematic and the randomized controlled trial. So when there is a prosthodontist saying to me, okay, when I should put my crown? I said, as long as there is no sinus symptoms. When I say sinus symptom, doesn't mean a lesion. Okay, I'm saying sinus symptoms like a percussion, a palpation, or there is a sinus tract. That's it. If there is nothing of these, you might go next week to do your crown. You will not wait longer, okay, because this means leakage in the filling. It might weaken the tooth. The lesion by itself, it will heal in 6 to 1 year to 2 years. You will not wait that time. We'll just follow it up. So immediately after finishing the root canal, you immediately go and do the crown or the filling. And that's why I recommend most of the time, when you do the case or retreatment or treatment, and you will send it back to the other colleague for the coronal or for the crown, whatever. Don't do or just put temporary filling, okay? No, you can go and do like a double seal, just do like a small layer of cavit or zinc oxide, and at the top of that, you might use GIC, that big bulk of GIC, okay? So if you need to go do the post, okay, then after removing the GIC, you can find the temporary filling easily, you can remove. But I'm trying to make this tooth isolated, okay, and sealed for the longer time. I don't know when he's going to do the crown. If it's next week, and I'm sure, okay, yes, okay, cavity will be fine. But reasons, okay, so many things can happen. So use it as a double seal all of your time practicing when you're doing endo. Small temporary filling, at the top use large of GIC, might stay for 1 or 2 months. It's up to you, okay, or for the physician when he's going to start, but at least you save that tooth, okay, for sealed for a longer time. Now, what can the factors that can affect the healing? Size of the defect. When you have a large lesion, okay, it's not like a small lesion. So the larger the lesion, it will take a longer time. When you see an X-ray, okay, with a small lesion, that's a 2-dimension. If you take a CBCT or you open it surgically, you'll find it wider and double size because of the cancellous and the spongy bone, okay, is different, okay? When is the lesion can show in the X-ray when it breaks the cortical plate. You might have some lesion inside, but it doesn't show. Patients, some people can have pain when I bite on this tooth, and you look to the X-ray, oh, there is nothing. If you open it or take a CBCT, you might find a lesion, okay? So don't always look to the 2-dimensional X-ray and you think there is no lesion. The size is a matter. If you see a bigger size in a 2D X-ray, it's suspected to be double the size, okay? And the healing will longer time. The foreign material, let's say if you have an overextended, okay, Gutta-Percha or sealer, whatever material is in that lesion, the body reaction, okay, it will take some time longer because of dealing also not only with healing, but also with the foreign material. Can it cause a failure? Very few times, okay, can happen. It lowers the success, but it doesn't mean it's failed, okay? If you say to me, okay, a shorter root canal filling or overextended, no choice. Let's say, okay, I don't have any choice, either over or less. Over, yes, it will be affected, but shorter, okay, that means still a bacteria there, it didn't clean, okay, so still I have a source of infection. Yes, here I pushed, okay, more. Both of them are wrong, but the ideal is the optimum, but it doesn't mean, okay, it's the same as if it's short. If you have a medically compromised patient, especially I'm talking about diabetic, okay, leukemic patient, anything can affect the immune system. When you have a diabetic patient, especially the uncontrolled diabetes, the healing, okay, it's like a healing of a wound. It's the same thing. It will take a longer time. Even it might fail if it's not having a good, okay, blood glucose level, okay, especially if it's below, not below 7, it's like above 7 to 8 and more. So the failure is higher, okay, in these cases, especially the patient, okay, is not taking care of himself. So it's not a failure of you, okay, you did your work, but the human, okay, and the immune system inside is not functioning properly, okay, and that's the failure, okay. So even you might try and retreat, but you have to control it. So it's not only a factor of bacteria, but also there is a factor of the human itself. So when you have a diabetic patient, you have to be aware with him about the glucose level, okay, and what's the consequences if it's not properly adjusted. Post-treatment consideration, flare-up, okay, final coronal restoration, follow-up visits, prognosis of the healing. When you talk about flare-up, what things, okay, can cause a flare-up? any retreatment, especially with the patient comes to you with a lesion, okay, a large lesion, okay, and he comes with a pain, okay, and if the female is more. So these all are indication that you might have a flare-up. Flare-up, that means the patient you start today, the next day will come to you with a swelling or a pain or severe pain. To reduce this one, okay, you have to minimize the amount of the extrusion, okay, that will go to the apical part. Always try to be inside the canal. Crown down preparation. Try to use always the crown down tube instead of the step back, okay? Because this can push more debris in the apical area. Thoroughly cleaning and shaping the initial visit, okay? Don't try, okay, I'll just remove just one canal, okay, and leave the other. No, okay? You're just irritating the case. Clean and shape well from the first visit. Yes, you might have flare-up next visit, but it will be much more easier, okay, for you to handle this case. If the patient comes to you, okay, also don't keep the tooth open. If you have like a pus coming out, and this is a very big aspect that you always debating about this point. If you have a pus coming out, okay, keep it, okay, it will stop, okay. I didn't see a case that will stay 1 hour, okay, oozing pus, okay. You can close it, okay, half an hour maximum. I haven't seen a case more than half an hour oozing. Then you can close it. This patient, okay, you can tell him you will have pain, you will have swelling. The next day, keep in contact with him. If he can, okay, you might come as an emergency. You might open the case the next day, clean it. It will be fine. Close it again. Next week, you will obturate it. If you just follow just to remove the temporary filling and just keep the tooth open, okay, just to make the gases less, okay. So what's the point of the clean and shave in the canal? Okay, from the first visit, there is a fluid and saliva came inside. So it doesn't make sense, okay? So these cases, when a patient comes to you with the pus oozing out, just keep it on your chair, make the pus comes out, and then after that, okay, next visit, you might say it's an emergency visit. Next day, you might call him, how you feel, you still have pain, okay, come back, okay, you might open and clean. Most of the time, it's 2 visits, the first and the second, and then the third, the next week, it will be an obturation, especially like these type of cases where you have pus oozing. Now, the worst case is when I have a patient comes to me, okay, and the tooth is open, okay, so you already started the case with someone, and the longer the time the case stay open, that's a bomb case, okay, because by the time, okay, this patient sits on the chair, I'll tell him, okay, I will clean and shape today. There is a high percent that you will have swelling. You might have severe pain, okay, you might have it tomorrow after tomorrow, okay. You might come to me, okay, then I open it again, it might be pus or nothing, clean and shape, and then next week, okay, or 2 weeks, okay, you might finish the case. But you have to be awareing the patient what's the things that will happen. This can make the patient knows what's the worst thing can happen, and if it happen, he knows that it's a normal thing, and then he will not go with the same concept, I need to remove that filling so I'll be happy, and the tooth will become relax from the pain. And this is a concept that I want to change, okay, especially from practitioner and the patient, because those patients will not take this information from their side. It's from the practitioner to keep that tooth open to just relax the pain, but it doesn't make sense. You clean and shave and there is a food goes inside. 2 visits, okay, there's a big debate, okay. 1 visit, if you don't have any pus or anything or any lesion, you might go for 1 visit. But if the patient comes to you with a severe pain, retreatment, okay, you might clean and shape that visit and you can obturate the next visit. It doesn't make any sense. Not all of your cases will be the same as this case. Maybe 1 out of 10, 2 out of 10, okay, it will not make big change in your schedule. Now, the fire coronal restoration, this is one important thing for the follow-up. That's why I want to make a follow-up to see if it's sealed or not, okay? I want to see because this will protect the tooth and will prevent the coronal micro leakage, and it will avoid, okay, future retreatment. Because if this tooth, okay, still with the temporary filling after 3-4 months, it's already leaked, okay, zinc oxide, cavity, whatever, okay, that means there is a leakage. Are you going to just only send it and crown it? No, this will need a retreatment. Now, the expense of that retreatment, is it your fault or the patient's fault or the prosthodontist's fault? That's a big problem, okay? And this is the way how you have to be always clear with the patient that you need to finish it sooner, okay? Don't keep it like this, or you go for a double seal or a fine restoration, and how trustfully with your colleague in the prosto part. Now the follow-up visits, okay, when you want to see if the tooth is restored, we want to see if there is any sign of symptoms, the healing process. And this is the most enjoyable part for the endo, to see how the success of his treatment. This is what we see, okay? For the process and for other field, they look to the aesthetical part. We look for the healing part, because this is show how am I doing and how I'm going with my way of how to treat these cases. Radiographic healing, and the initial follow-up is 6 months, okay, then goes for 1 year, then you might go yearly till 4 years. Why I say 4 years? Because 2 years is the period where we have the healing, but the most of the cases when there is a collapse or for okay, it's return back, okay, is after 2 years. So 2 years is the max, okay? 3 years after 1 year, and 4 years. This is the maximum, okay, I can go for. This is a healthy patient. But if that patient is a medically compromised patient for anything, immune disease or diabetic patient, you might take a longer time, okay? And you just follow up these cases. In the literature, there is many cases, that's very few cases that stayed for 7 years or 12 years. It's very few, okay? But this is the average, 2 years to 4 years. Now, the prognosis, definitely after all of this invention and the retreatment from the files, from the microscope, from the ultrasonics, okay, from the material, we reach to 95.5% success. And that's something can save the tooth, okay, from extraction and from implant. We're not against implant, but we can save a natural tooth, okay. Definitely it's better than an implant, and also this is for the health and the socio-economic of the patient. Many things, okay, that we can do from the retreatment. Thank you very much. I hope it was